All right, guys, so we're going to get started. Can everyone hear me okay, or do I need to move the mic up? Is the back row okay? Yeah? Louder? Good? All right. Scoot this up a bit. Better? Worse? Okay, cool. All right, so for those of you that don't recognize me by now, my name is Mark. I'm the head TA for the face-to-face lab. So some of you might see me Fridays just kind of hanging out. I'm doing my own thing. Some of you guys might be bugging me with questions. It's awesome to see you guys showing up to these labs still, and hopefully I'll see you guys on Friday. But we're going to be talking today about the muscles of the medial thigh as well as the posterior thigh. So for those of you that were here on Tuesday, I believe Dr. Merrifield talked about some of the muscles of the medial thigh, or anterior compartment. Rather, I'm doing medial thigh. So he talked about the anterior thigh. So today we're going to finish up the thigh and talk about the medial and posterior thigh, as well as some of those the back muscles, so the gluteal muscles. So before we begin, I thought I'd ask a poll question. So the way this poll is going to work, if I could there's about 30 people here maybe, and there's probably a few people online. So I have some additional slides on my PowerPoint that you guys don't have. Some will be, I think, useful for you. I have some animations of every single action that the muscles are doing. And I don't mind posting these slides, but I do want some participation from you. So there'll be about 4 questions during this lecture. And all you'll have to do is click on that link or open it up on your phone. You can use your computer if you have one. And anytime you see that link, you can just select A, B, C, D, or E, and your answer will be registered. And if I get at least probably half the class answering for the 4 questions, then I'll post my slides that has those blanks filled in as well. So you can just sit back and relax as long as you participate. So first question, how often do you do leg day? So for those of you that work out regularly, I know a lot of gym bros like to skip out on the legs and focus more on their upper body. So is your answer A, never? You have no clue what leg day is. Do you do it occasionally? Or maybe somewhat regularly, so you try for once a week, but you get lazy one week and skip leg day. Maybe you do it regularly, or every day is leg day. You really want to get those nice glutes that a lot of models are showing off these days. So I'll let this go for another 15, 30 seconds. Let you guys go to that link, and we'll click it and see. We'll see how fit you guys are. All right, cool. So I have 34 responses. This is not bad. Let's see where most people lie. All right, so we have a pretty good distribution. Looks like most people are D, so they do them regularly. That could be cardio, I guess, running on the treadmill. I guess that'll count as leg day. Or you're going to the gym and lifting weights, doing some squats and stuff. And as I expected, a decent amount are doing it never. So it's interesting when we talk about these muscles. These are the biggest muscles in our body, and we use them all the time, but people always neglect them. So today I'll talk about these muscles. I'll tell you some exercises that you can do, and maybe we can get more people shifting towards the C or the D or even the E range. All right. So today what we're going to do, we're going to briefly talk about the bony landmarks that we'll be seeing today. So the pelvis, as well as the femur and fibula and tibia. We're just going to do that really briefly because you should already know most of these structures by now. Then we'll move on and talk about the gluteal muscles. So that's your butt muscles that you guys are all sitting on right now, unless you're online and you're standing up making breakfast or something. Then we'll talk about the 5 adductor muscles, so the medial compartment of the thigh. We'll then finish up with the posterior compartment. And the other couple questions I'll be asking you are going to be more clinical cases or putting it into an exercise perspective. So we're going to be trying to diagnose nerve damage or muscle weakness based on symptoms that patients present with. This is something that for lots of you, I'm sure, are thinking about going into med school, and you're probably learning this anatomy and you might not realize how important knowing this stuff actually is. So you'll be able to diagnose clinical stuff just with the information that we'll talk about today. So, as I said, we'll start by talking about the bony landmarks. You've seen the pelvis a million times. You probably saw it on Tuesday. You probably saw it the week before. So I'll just talk about the key landmarks that I'll be mentioning today a few times. So the pelvis has 3 bones, and the top bone up here is the ilium. We're not really focusing too much on the anterior aspect of the ilium today, so don't worry about the anterior superior iliac spine up here if you remember that from last week's lecture. We don't really care too much about the ilium, but just remember that's kind of where it's sitting. More anteriorly, as well as a little bit more inferiorly, we have the pubis bone. And there will be a couple landmarks on this bone that you'll have to know. So we'll start with the body of the pubis, so that's going to be the most midline portion. And then it has two arms that project. So we have a higher one, which is called the superior pubic ramus. And then below that one, we'll have the inferior pubic ramus. And, oh, of course, don't put Remus for Remus Lupin, for any true Harry Potter fans, on a bell ringer. Interestingly enough, I got this once, and I saw someone write Remus instead of Ramus, and now it's kind of ingrained in my head. And so I picture the body of the pubis as being Professor Lupin kind of standing there, and then his arm, he's about to cast a Patronus charm or something, so his arm is waving the wand, and Ramus means arm. So superior ramus is his arm, kind of casting that spell, and then he's forming the body more towards the midline. Okay, so I don't want to see any Remuses being written down on the bell ringer if that pops up. Okay, but there's going to be a muscle coming off the superior one. There'll be stuff coming off of the inferior pubic ramus, or the inferior arm. And then there's going to be a ridge. It's found on both sides. I just highlighted the one ridge there, and that's the pectineal line. And we'll see a muscle called the pectineus, which is going to be originating right off of that. So the name, I like that one. It tells you exactly what muscle is coming off of that ridge. Okay, so that's the pubic bone. And then finishing up the pelvis, we have the ischium. The only real landmark to talk about on this one today is the ischial tuberosity, of course, is there, but the main one, or the ischial ramus is there. The main one's the ischial tuberosity. So that's that bone that you're sitting on right now. We're going to see a lot of muscles that are originating on the ischial tuberosity. Okay, so most of those landmarks should seem familiar to you. I'm going to show you those same three bones, but now from the back. After I just pointed out sacrum and coccyx are there. Okay, so from behind, we have the ilium. Remember I said there was no real important landmarks on the anterior surface, but there are a couple on the posterior surface. So we have these three ridges. I don't quite like the way they're named, but there's one ridge that's found posteriorly, and it kind of stops and stays posterior, going up to the iliac crest. And that's going to be the posterior gluteal line. And so some of the gluteal muscles are going to be coming from there. More towards the middle of the ilium, we have another ridge. This one's called the anterior gluteal line. I guess it's called anterior because it starts, where's my mouse? I guess it starts more anteriorly, so it's called anterior, whereas the posterior one just stays sort of posterior. And then we have the inferior gluteal line at the bottom. Okay, so those are the three lines on the ilium, and we'll see the gluteal muscles kind of originating from part of those ridges. Pubic bone, we've already talked about those from the front. There's nothing really from behind to see. And then again, the ischium, main one is the ischial tuberosity. Okay, so those are the main origination points for all the muscles I'll be talking about today. I think there's, 5, 3, and 3. So over 10 muscles, but there's not too many originations for you guys to memorize, which is nice. And then, of course, sacrum and coccyx. Okay, so let's see where most of these muscles will be inserting. So they're coming from the pelvis. They're going to cross the hip joint, so they'll be acting on the hip in some way. And then they'll insert, for the most part, onto the femur. So if we have the head of the femur, that's going to be where it articulates with the pelvis. So that's the medial side towards the right of the screen. And then the left side is the lateral. And we can see a big bump sticking out on the lateral side. So that's called the greater trochanter. And we'll see some muscles coming from the medial side of the body, and then they'll come across and attach onto that greater trochanter. And if you have a greater of something, you usually have a lesser. And so you have a lesser trochanter on the medial side. Again, same thing, we'll have some muscles around that area. And sticking anteriorly, we have two bumps as you go a bit more distally, lateral and medial condyle. Okay, so those are the four you have to think about for the femur from the front. And if we flip this guy around to the back, I'll come back to that one. If you flip this around to the back, again, we see a huge bump on the lateral side, greater trochanter, smaller one on the medial side, which is the lesser trochanter. We can still see those medial and lateral condyles at the bottom as well. But we can also see some ridges, if you look really closely, kind of moving along the entire shaft of the femur. So there's one ridge that extends from the greater trochanter, more laterally, down towards the middle. And that is called the gluteal tuberosity. And as you can imagine, some of the gluteal muscles might be attaching onto there. There's also a ridge from the medial side, from the lesser trochanter down to join up with that, and that would be the pectineal line, where the pectineus will attach. So if you already remember the pectineus, you have a pectineal line on the pubic bone, you have a pectineal line on the femur, and so that muscle is going to run connecting those two regions. And then those two ridges will join together in a bit more in the middle part of the shaft and form a thicker ridge, which is called the linea aspera. And we're probably going to see 8 of the muscles today are attaching to linea aspera. So get used to remembering where that one is, right on the back of the femur, right in the middle, running basically all the way down the shaft. It's the linea aspera. And then this ridge is going to split into 2 more ridges, a medial and a lateral side. They're right above the condyle. So medial supracondylar line and the lateral supracondylar line. Okay, so hopefully that naming kind of makes sense. And last few, the osteology before we actually dive into the muscles and the more fun part. So we have the knee, we have the femur up at the top. You can see a piece of the patella. And here we have the tibia highlighted in green. And very easy landmarks. Lateral tibial condyle on the lateral side. Medial tibial condyle on the medial side. And then we have a region on the medial aspect of the tibia, which we're going to scientifically just call the medial aspect of the proximal tibia. Okay, so those are the 3 basic landmarks that we'll see on the tibia, and any of the muscles that are attaching onto those condyles or onto that proximal aspect of the tibia are all going to have some sort of action at the knee joint because it's crossing the knee. So we'll see if that does flexion or extension, but it will be doing something. And then we have the fibula. It's one major osteological landmark, which is just the head of the fibula. Okay, so does anyone have any questions on kind of the basic osteology? You've probably seen this by now, so it should be pretty good. Yeah? Okay. So let's get a bit more into the fun stuff and actually talk about the muscles. So I'll start with the gluteal muscles. There are 3 of them: gluteus maximus, gluteus medius, and gluteus minimus. And those are your butt muscles. And they're basically just arranged in 3 layers. So you have the gluteus maximus, which is what you're all sitting on. And then a little bit deeper to that, you would have gluteus medius. And then even a little bit deeper to that, you'd have gluteus minimus. Okay, so let's look at those individually. So we'll start with gluteus maximus. Big muscle. This is actually the largest muscle in your body. It doesn't matter if you're measuring it by cross-sectional area or by volume or by weight. It's the largest muscle. So it's going to be the large chunk of your entire glutes are going to be glute max. And if we remove the muscle, we can see in red where it's originating and in blue where it's inserting. And since we just did this osteology, hopefully you can figure out what some of these landmarks are. So in red, with just the dorsal or the back part of the ilium, the sacrum, and the coccyx is where it's starting from. And it's going to go across the hip joint, insert below that big lateral bump on the femur at the gluteal tuberosity. Okay, so this muscle is crossing the hip joint from behind, which means it's going to act on the hip joint from behind. And so when we think about those functions, hopefully that will kind of make sense. The nerve supply for this one is the gluteal nerve, and it's in particular the inferior one. And I'll get back to why it's the inferior one in a minute once we talk about the other gluteal muscles. So just keep that in the back of your minds. So the functions of this, we have extension, abduction, and lateral rotation of the hip. So what exactly are those motions? Just to refresh us. So here is the leg with some of the muscles removed. The muscle that is in red is the glute max, and when it is red, it's contracting. Okay, so it's actually doing the action, and when it's not in red, it's just going back to its normal state. So we can see as it's contracting, your leg is getting kicked backwards. So you're getting extension of the hip. We're also getting abduction, so it's going to pull the top of the part of the femur, and that's going to cause your leg to move upwards or abduct away from your body. And then finally, there's also lateral rotation of the hip. Okay, in this case, the knee is bending in this animation. It doesn't necessarily have to be bent for you to still get lateral rotation. And I know you guys are probably sitting right now, but if you even just laterally rotate your leg, you can probably feel your glute muscle starting to contract. Okay, so those are 3 actions for glute max. And so now we'll look at gluteus medius. So picture ourselves, we were taking this muscle and we're going to remove it completely. and look at this next one. So I guess you guys can't see my, okay, here we go. So glute medius, if you remember, glute max was coming off of right here and then inserting down into this region right down over here. Our gluteus medius is going to be a bit more superior, so a bit higher up, and you can keep that in mind when you think about the nerve supply. So if I remove that muscle, we can take a look at where it's coming from. And we think back to the back part of the ilium, we had those 3 gluteal lines. This one, glute medius, is high up, so it's coming from this posterior line, which was here, and this anterior line, which was here. Okay, so it's just going to sit in between those 2 lines. And then it's going to run down and attach onto this big bump, lateral side of the femur, greater trochanter. Okay? So nerves. Gluteal nerve, because it's a glute muscle, and in this case it's the superior one, because again, if you look at where glute medius is, even though it's deeper than gluteus maximus, it is overall more superior. So it gets the superior one, whereas glute max was sitting more kind of down in this area. So it's getting the inferior one. Okay. And the functions of glute medius is abduction, so again, moving your leg outwards, away from the midline, as well as medial rotation. So I want you to keep the rotation in mind. Gluteus maximus was doing the lateral rotation. Glute medius does the opposite. So it's going to move your leg in towards the middle. And that's why you can see the front part of the femur being shifted towards the midline, or more medial of the body. Okay, and we can see this one clearly is not working, but there would be abduction as well. Okay, so to finish off with glute minimus, now picture yourselves taking medius, and now we're removing medius. We're going even deeper to glute min. And again, we're looking at it. It's coming from the back part of the ilium. There were those 3 lines, but now it's not going up as high. It's minimus. It's not as big. And so it's going to come from the anterior line as well as our inferior line down here. You'll see that once I get rid of the muscle. Between the anterior and the inferior gluteal lines. It's kind of hard to see in this view where it's inserting because I have the pelvis a little bit more rotated, but it is inserting onto this greater trochanter area. And so if you picture this muscle contracting and you compare it to glute medius, which is what we just did, hopefully you can see that they're basically going to be identical. Okay, so they're both going to do abduction, and they're both going to do the exact same medial rotation. Okay, and because this muscle is a little higher up in the pelvis, it gets the superior gluteal nerve, whereas glute max gets that inferior one. Okay. And again, just to show you these functions, so on the left, you can see gluteus maximus is kind of faded right now, and glute medius is also kind of faded, and that muscle contracting at the top getting red is that tiny little gluteus minimus. Okay. All right. So the glute medius and gluteus minimus also have another function, and that's posterior pelvic tilt. So I'm actually just going to stand over here just so you can see kind of what that action means. So I'll get the camera on me too. Okay, so if I picture where my pelvis bone is, that's right here. My anterior superior iliac spine is sitting right here. So posterior pelvic tilt is basically taking that spine and moving it backwards. So instead of sitting kind of like this, I'm now twisting posteriorly. Okay, so from anterior to posterior. So it's a really subtle movement. And as I was doing that movement and practicing what posterior pelvic tilt was, I asked a very important question: does posterior pelvic tilt, which is basically what you're doing when you're twerking, is that using gluteus medius and gluteus minimus? Because they're doing that motion of posterior pelvic tilt. So I wanted to know if these muscles actually do that. And it turns out that they actually don't do twerking. So I guess when you're twerking, I'm by no means a twerking expert, or I demonstrate, but I guess you want your glute muscles to be as lax as possible and loose. So I guess you get that jiggle, kind of like what we're seeing there with Squidward. And so you don't actually want to use your glute muscles for that. So if anyone's a twerking expert that's done it a lot, maybe you know that you feel a lot of pain in or soreness in your back, and it's actually your erector spinae, those deep back muscles that you learned last semester, I guess. So those muscles are the ones that are mainly doing the twerking, and glute medius and gluteus minimus are just kind of jiggling. Okay, probably will not come up on the exam, but now you know. All right, so let's ask a question that might actually be on the exam, a bit more clinically relevant. So this will have voting. I'll let you watch the video first, and then I'll open up the polling. So there's this condition called Trendelenburg gait, and it's caused by neuromuscular weakness of some of the muscles that we just talked about. So I want you to look at the way this person's walking, and hopefully you can kind of see that it is abnormal. And if you think about those muscles we talked about, some of the muscles help stabilize your pelvis when you're walking. Okay, so hopefully you guys have got that by now. So I'll let you guys think about it for about 30 seconds. We already have some people, some keeners doing the voting. Awesome. So do we think it's the gluteus maximus, first of all, or do we think it's gluteus medius and gluteus minimus? And then probably the more difficult question is, which side is it? Is it the left side or is it the right side? Okay, we'll give another 15 seconds. Feel free to stand up if you want, and I don't know if anyone actually will, but you can stand up and you can walk and you can try and see which muscles are contracting. Now would be a good time where if you're bored, I guess you could just get up and sneak away and no one would really notice, because I said you could walk. Yeah. All right, so we've got 30. It's good enough. So let's see where we're saying. Okay, so we have the majority of people saying B, with D kind of following suit. So those are both the gluteus medius and gluteus minimus. So that's correct. So that's stabilizing your pelvis when you're walking, and it's keeping your pelvis level. So in the case of this patient, they were walking and one pelvis was kind of sagging out. And I'm actually going to leave this question for now. I'm not going to tell you the answer. I want you guys to keep thinking about it. So when you actually walk home, think about what muscles are contracting when one foot's on the ground versus the other foot. And we'll talk about this question again in lab today, I guess, if you're in online, or today's Thursday, or tomorrow in face-to-face. Okay. And last thing I want to talk about for the glutes is building a well-rounded booty. So a lot of you guys said you never work out leg day. So I'm just going to quickly talk about ways that you can get in the gym. So this isn't really just specific to the glutes. But you always want to start with just some pre-activation movements where you're basically just getting blood flowing to your muscles, you're getting your joints loosened up. So kind of what we're seeing on the image here, just doing body weight squats, doing body weight lunges, nothing too crazy. And then pick one or two compound exercises. So a compound exercise just means you're moving more than one joint at once. So you're doing hip extension, but you're also doing knee flexion or something like that. And generally, you can do heavy weights for that, and because you're recruiting really large muscles. So stuff like the hip thrust, I know a lot of girls love to do that one in the gym, and it's a great exercise for the glutes. You can do glute hamstring raise, which I'll talk about again in a little bit, so if you don't know what that is, it's okay. Squat, and I have in brackets to use a wider leg if you're going to do squats with your toes pointed laterally. And if you remember me saying gluteus maximus is the biggest muscle, gluteus maximus does abduction of your feet, so that's why you might want to stand slightly more abducted. And then if you point your toes laterally, that's the lateral rotation part, so that's going to target the gluteus maximus more and engage that one even further. So pick about one or two compound exercises, then you can move on to isolation exercises, which just means across a single joint. So instead of doing hip extension and knee flexion, you're just doing hip extension, for example. And stuff like just simple adduction or kickbacks, so extension against resistance. And again, you can do high reps for that. Interesting thing I found about the glutes from my scientific reading, you can actually target them 3 to 4 times per week, and they'll be totally fine. So some muscle groups you can't do that often. You'll only be able to do them, say, twice a week. But the glutes, because you're using them all the time, they can take quite a beating. So everyone that said they're only doing it once or twice, if you really want to get glutes, you can up that to 3 to 4 times. And I've included some links to some YouTubers that talk about great exercises and that actually go into the scientific background and scientific literature about it. So anyone interested, feel free to check that out. Again, probably not going to get tested, but might be good if you're trying to get into the gym for your New Year's resolution. Okay, so does anyone have any questions on those glute muscles before we keep going? No? Okay, cool. You'll get to see those in lab if you show up on Friday, if you're in face-to-face, or if you want to come for that 1 hour break for the online students. I highly recommend coming. It really helps to see these muscles. Even these pictures, because it's 2D, it's sometimes kind of hard to see how some of these muscles are actually acting. It makes a lot more sense if you come in. Okay, so we'll get started with the medial thigh now. There's 5 muscles to know, and I know some of you are already probably rolling your eyes. That's 5 more origins, 5 more insertions, 5 more nerves. So it's a lot of stuff. In general, though, I like to learn the general rules and then just focus on the exceptions. So if you learn these general ones and just learn the 5 or so exceptions, you have a way less memorizing to know. Okay, so in general, the medial thigh muscles are going to be coming from the pubic bone. And we talked about some of those landmarks like the superior pubic ramus, the body. It really doesn't make too much of a difference for your course where they're coming. So thinking pubis bone, if you for some reason blank on an origin, just pick pubis bone and you'll probably be good. In general, they insert on the linea aspera of the femur, which is that back ridge running right down the femur, and we'll see that again. The nerve supply in general will be obturator for 4 out of the 5 of them. And the function is adduction and flexion of the hip. Okay, so if you just learn those 4 general basic things, you basically already know all of the adductors of the thigh. But we're going to start with the one that's kind of more of an oddball, which is pectineus. We've already talked about its origin and insertion, pectinea line to pectinea line. So even though it's a little bit, it doesn't quite fit that linea aspera, the name kind of tells you right where it's going. And this nerve is also the exception. So femoral nerve, sometimes it's the obturator. Does anyone remember what, in general, the femoral nerve is innervating? Think back to Tuesday. Someone was here? Yeah.
Anterior compartment of the thigh.
Right, yeah. So in general, femoral nerve is doing the anterior compartment. And so pectineus, if we're looking at it in comparison to the other adductors, and I'll show you that in a minute, it looks like it could kind of be an anterior compartment or a medial compartment, just in terms of where it's going. And so to me, it kind of makes sense that femoral nerve can kind of do that too, just because it's really close to all of the other anterior compartment muscles. Okay, but it is an adductor, and so its functions are flexion and adduction of the hip, just like all the other ones. So I'm going to put this up here so we can see pectineus sitting right here in red. Okay, so we can see all the other adductors are over here, so more medially, but pectineus is kind of really close to all of these quads in the anterior compartment, so that's why it's getting femoral. And we can see flexion. We can also see it doing adduction, so bringing it towards the midline. I have put medial rotation as well. I think your textbook says medial rotation. It does do medial rotation. You guys are totally fine with just ignoring that and saying it does adduction and flexion. So just treat it as a typical adductor. But I just wanted to put that on just for completeness. Okay, so that's the one kind of exception. Of course, there's always a bit more. So here's the second one. Gracilis. This is the muscle right in the medial part of your thigh, so the most medial muscle. So pectineus would have been running kind of like this. And now we have gracilis running all the way down. So it's still pubis. Still body of the pubis, part of the pubis. But now instead of inserting onto the linea aspera, it's going all the way down to attach onto the tibia. Okay, and I put a line under tibia. I wanted you guys to write tibia because this is the one adductor that does cross the knee joint. And if it crosses the knee joint, it acts on the knee joint. Nerve supply, obturator, nice and simple. Functions. So it's still doing adduction of the hip, so it's going to bring your hip towards the middle. But now instead of doing flexion of the hip, it does flexion and internal rotation of the knee. Okay, so it's actually crossing the knee and flexing the knee as opposed to flexing the femur. Okay, and we'll see that in action right now. So most medial muscle, it's going to adduct, bring it towards the midline. It's crossing the knee joint from behind, so it kind of flexes the knee. And it's going to do medial rotation. Now the knee doesn't rotate a heck of a lot. You have to look really closely at this to see the rotation. And it might help to kind of look at the toes and see that the toes are moving a bit more medial. Even though the toes are on the ankle joint isn't moving. So it's just showing the knee itself actually moving, pulling that a bit more medially. Okay, so that's two of them. A couple exceptions there. Get into the nice simple ones for a bit. So adductor longus. This is like the key adductor muscle. I love it. Look where it's going. Body of the pubis. If you look at where it's inserting, right on that linea aspera, so the back ridge, the nerve supply, obturator nerve. And if this was a perfect muscle, it would do flexion and adduction. And lo and behold, flexion and adduction. Okay, so if you learn those general rules, you can basically forget about learning adductor longus. You already know it. And you just need to be able to identify it. And so it's going to be between pectineus up here and gracilis, which was running the most medial. Okay, so it's going to be that third medial muscle that we can see. But again, flexion and adduction. Okay, and if you have a longus muscle, you usually have a brevis. And essentially, they're very similar muscles, just a little bit smaller in general. So we'll see that with brevis as well. So looking at the red, might be hard to see, body of the pubis. This one, because it's brevis, it's a little bit of a shorter muscle, so it might be also attaching on the inferior pubic ramus instead of just the body. But if you remember that's brevis, it might make sense it's a little bit lower down. It's still inserting on the linea aspera, though. It's still a medial compartment, so it's still going to be obturator nerve. And functions of that, flexion and adduction. Okay, so now you know adductor longus, you know adductor brevis. They're typical adductors. The only difference really between these two muscles is that the brevis is going to be sitting deeper. Okay, so in order to see adductor brevis, you would have had to have removed adductor longus. And in this case, I just faded it a bit. But if you go deep, essentially it looks like the exact same muscle. That's your brevis. Okay, so the last adductor is adductor magnus. This muscle is also a huge muscle, and it's kind of hard to appreciate how big it is and how thick it is until you come into the lab and see the prosections. But if we remove the muscle, we can see ischial in pubic rami as well as the ischial tuberosity. So I'm going to come back to this one. It's a little bit different. It still is coming from the pubic bone, but now we're also seeing ischial tuberosity as well. Part of it's inserting onto the linea aspera down here. So a typical adductor. Part of it, though, is also going a bit further down to insert onto the medial supracondylar line, which is that line right above the medial condyle, and a little bump called the adductor tubercle down here. Okay, so it doesn't quite look like an adductor muscle, at least 100%. And so it is obturator nerve. There's also sciatic nerve as well, which we haven't talked about yet, I don't think at all, in any of your muscles. Sciatic nerve is going to be running right down the back of the leg. It's the biggest nerve in the body. It's really thick. It's going to be doing all the posterior compartment that I'll be talking about in a minute. So all your hamstrings are sciatic. So anytime you hear sciatic, think back of the leg. So adductor magnus gets half of that. It also gets the obturator. And if you look at the functions, I would love to say it does adduction and flexion of the hip, and that's it. But it also does do extension as well. Okay, so I like to break this muscle up to make things a little bit easier to memorize, because there's a lot of origins, a lot of insertions for it. And so you can break this up into two parts. I don't think you have these, but you can break it up into an adductor part. And so if you're looking at the adductor fibers, they're going to be coming from typical adductors, so the pubic bone, going to the linea aspera. And so when that muscle pulls, you get flexion and adduction of the hip and obturator nerve. Okay, so the adductor part of magnus, exactly like adductor longus, exactly like adductor brevis, exactly like your typical adductor muscle. And then it's just this hamstring part of it that's a little bit funky that you guys aren't used to seeing yet. Okay, so the origin is the ischial tuberosity, so more posterior. It goes all the way down to this part down here, sciatic nerve and extension of the hip. Okay, and this is going to make more sense when I talk about the hamstrings in a minute, but this is almost textbook-ish of a hamstring muscle. Okay, so if you know your hamstring muscles, you just take part of the hamstring stuff, part of the adductor stuff, mush it together, you got adductor magnus. So if we take a look at those actions, again, adductor magnus, a huge muscle, but it's really deep, so you have to remove all those other adductors that we talked about, and it's going to flex the hip because it's an adductor. It's going to adduct it like all the other adductors, but it also does extension as well. Okay, and it's kind of weird to think about a muscle that does extension and flexion of the same joint. This is one of the few that does that, and it does depend on the orientation of your leg, but know that it does do both. Okay. Okay, does anyone have any questions on any of the adductors? Okay. Question time. So this, again, is not a question you'll see on your exam. If you're trying to go for med school, this is something that you'll probably see these types of questions. And this is how we kind of relate origins and insertions and muscle functions to more clinical stuff. So a 56-year-old male has been diagnosed with bladder cancer that has metastasized to external iliac lymph nodes within the pelvis. That's a mouthful. You probably have no clue what that means, so I'll talk about that in a second. What nerve is at the greatest risk of compression because of this metastasis, and what would the functional consequences be? So to give you guys some context, we're talking about the pelvis, so I'll stick in a pelvis. We're talking about what nerves are going to be at compression. So let's think about the nerves we've talked about going into the thigh. So we have our femoral nerve, and I know you haven't seen the paths of these before, but the femoral nerve we can see is coming towards the anterior compartment of the thigh, and it runs right along the ilium. Okay, I'll put in another nerve, which is going towards the medial part of the thigh. So this is going to be the obturator. So the obturator comes up through this hole, runs along the inside of the pelvis, and then goes up to the spinal cord. And then the sciatic nerve, which I've just briefly talked about, is that big nerve all the way at the back part of the pelvis. And it's kind of hard to appreciate going anteriorly and posteriorly, but this is quite a bit posterior, and it's going to run all the way down the back part of the leg. Okay, so think about the courses of those three nerves. And I'll put in the bladder. So bladder is sitting right here, right behind the pubic bone. I'm going to put in an artery and vein. You guys haven't talked about these yet, but these tiny little green things, if I just cycle between them, these are the lymph nodes right here. Okay, so you have cancer in your bladder. It's spreading up into this region, and they're going to swell up, and then they're going to compress one of the nerves that are closely in this region. Okay, so let's think about first what nerve that is, and then we can also think about then what the consequences will be. Okay, so hopefully you guys have that picture in your head. I think it's on your slides. So I'm going to open up the polling now and see what we think. Do we think it's the femoral nerve that was coming in kind of laterally and then moving in? Do you think it's the obturator or the sciatic all the way at the back? All right, we'll see if we can crack 30. Okay, cool. Let's see what we're thinking. Awesome. Okay, so looks like the vast majority of you said the obturator nerve, which is correct. And then you're also saying, if you think of the functions of the obturator nerve, it's doing the medial compartment, which is adduction and flexion. So you have to knock out, so first of all, I'll just go back to talk about why it's that nerve. So the femoral nerve out here is just more lateral, and so it's very unlikely going to get affected by any tumor cells in this area. But the obturator nerve is this nerve that's running right along this inside portion of the pelvis, and that's right where those lymph nodes are sitting. So if those get big, it could compress on that nerve. And then you just have to knock out extension of the hip. So adductor magnus, we talked about, does extension, and so you might think that you lose extension too, or have some weakness, but if you remember, the extension part is done by sciatic nerve, So that part's going to be totally fine. Okay, so obturator nerve, you got weakness in adduction and flexion. Does anyone have any questions about that? Again, if you didn't get that right, don't worry about it. You're not going to get asked a question like that on your exam. But again, just think about the clinical relevance of the stuff that we're learning today. Okay. So we have done the medial portion of the thigh. We've done the glutes. Now let's just finish the last part of the leg and talk about the posterior thigh. 3 muscles. I've kind of separated them into 4 muscles, one kind of into 2. But in general, this is the hamstrings forming the whole back of the thigh. Okay, and again, general rules, just learn these and you'll have a lot easier time memorizing. In general, originating on the ischial tuberosity, just like that adductor magnus portion that we saw, it's going to insert onto a couple different parts on the tibia and the fibula, so that might vary a little bit, but it always is going to cross the knee joint. So no matter what, all these hamstrings are going to do something on the knee. They're all innervated by sciatic nerve, because that's all at the back of the leg, so that makes it easy. And functions, because it's going from the back of the leg, some of them are going to extend the hip, but we're also going to see flexion of the knee, and we'll see some kind of rotation. So as long as you know if the muscle is medial or lateral, you'll know what kind of rotation it is. So if there's a muscle coming from the lateral side of the leg, attaching to the lateral side of the tibia or to the fibula, then it's going to do lateral rotation. If you know it's coming from the medial side, then you know that it's going to do medial rotation. Okay, so it's always going to have kind of some kind of rotation, depending on where it's inserting, as well as extension of the hip or flexion of the knee. Okay, so semitendinosus is the first one we'll talk about. There's 2 superficial ones and then one deep one. So if I remove the muscle so we can see the origins, I know it's kind of hard to see. Origin, ischial tuberosity, just like any insertion, medial aspect of the proximal tibia. Okay, so it's going to come down and stick onto the front part of the knee, down in this region. So if it's on the medial side, we'd expect it to do medial rotation, which it does. It's a posterior muscle, sciatic nerve. Tibial branch, I don't think you really need to know that much in detail. You'll talk about those splitting next week when you talk about the leg. So you can keep that tibial versus the other part that you'll see in a minute in mind. It's tibial branch. And functions, extension of the hip, as I said, flexion of the knee, and in this case on the medial side, so it does medial rotation. Okay, so let's see how that looks. We're looking at a posterior view here. This is going to be the person's right leg. Okay, we can see the fibula here. So this is the lateral side. So this is a medial muscle, ischial tuberosity, crosses the knee, inserts onto the medial aspect. And so it does extension, flexes the knee, and then again, hard to kind of see, but it does rotate the knee about 10 or 15 degrees medially. Okay, so that's the one first superficial hamstring muscle on the medial side. Let's take a look at the one on the lateral side. So biceps femoris, it has 2 heads, has a short head and a long head. So I'm just going to separate them as 2 slides. You can think of it as one muscle if that makes it easier for you for studying. Long head, get rid of it a bit. Ischial tuberosity, just like any other one. Part of it is also coming onto the bone of the femur by the linea aspera, but it's definitely crossing the hip. Inserting onto the lateral side now. Head of the fibula over here, and the lateral condyle of the tibia, which would be in this region. Because it's on the lateral side, you'd expect lateral rotation, and because it's a posterior muscle, you'd expect sciatic nerve. So that's exactly what we see, sciatic nerve, and essentially the exact same functions as the semitendinosus, which we just saw, except instead of the medial rotation, it does lateral rotation. Okay, so just to see that again. Posterior view, muscle on the lateral side, extends the hip, contracts and flexes the knee, and now it does a little bit of rotation out towards that direction. Okay, so that's the long head. Let's contrast that to this guy, which is the short head. So the short head isn't as long, so it doesn't actually cross the hip. Okay, and this is the one important thing about this part. It doesn't cross the hip, so it can't do any hip extension. It's originating on the distal femur. It's kind of by the linea aspera, I'm sure if you said that on a bell ringer, you'd get the mark because it more or less is. It's just a bit slightly lateral. Distal femur is fine. Linea is fine. Inserts on the exact same spot as the long head. So the short and long head kind of come together and form one muscle and then insert. And the head of the fibula and the lateral condyle. So again, down here, crosses the knee. We expect some movement of the knee. It's a posterior muscle, so sciatic nerve. Hopefully I'm kind of sounding like a broken record, so it's ingrained into your head by now. But this one has a different branch. You can write common fibular branch for now. That doesn't have much meaning to you. You'll see these nerves again next week once you talk a bit more about the legs or the muscles of the leg and the lower leg, and you actually get to see those nerves in lab. Okay, so it's slightly different branch, but it's still sciatic. And the functions are just the flexion and lateral rotation of the knee. Okay, so it doesn't cross the joint, so it's not going to do any extension of the hip. Okay, and so if we're looking at that, it's going to be deep to biceps femoris, which would have been here. And when it's turning red, flex the knee and lateral rotation. Okay, so that just leads me to the last muscle, which is semimembranosus. Don't get it confused with semitendinosus, because it has a slightly different name, but I love it because it's essentially identical to semitendinosus. So, origination, ischial tuberosity, exact same as tendinosus. Medial aspects of the proximal tibia, exact same. Sciatic nerve, exact same. And so it does the exact same three functions. So it's essentially, for you guys that are trying to memorize, think of it as the exact same muscle. And then the only thing you have to do is identify one versus the other. And this is the one muscle that's deep in the hamstring. Okay, so we have semitendinosus up here, and it forms more of a tendon down at the bottom, and that's why it gets its name. So the tendinosus is really thin towards the bottom. Semimembranosus is thicker and more of a membrane type of muscle, and so it's going to be underneath, but running the exact same fashion. Okay, does anyone have any questions on the hamstrings? No? Okay. So last question, bring another exercise question for those that want to start leg day. Which exercise would be best for targeting all of the hamstring muscles? So A, the stiff leg deadlift. So think about what action you're doing when you're bending down and up. Essentially, you're doing back extension, but you could think of that as well as hamstring or as leg extension. There's the glute hamstring raise, which is doing back extension or hip extension as well as knee flexion. We have leg curls doing knee flexion, and we have the almighty squat, just doing primarily knee extension and hip extension. So, last question. See which ones you guys think. For anyone online too, feel free to talk to Ethan if you have any questions. I know he's got very, very large legs and he loves working out, so I'm sure he'd love to answer any questions about his workout routine. But let's see if we can crack that one more. Anyone? All right, cool. Let's see. All right, so we have not a lot of love for the deadlift, even though lots of people talk about deadlift all the time in the gym. And that's correct. So the stiff leg deadlift where your leg is straight doesn't really do a whole lot of hamstring because your hamstrings or your hips aren't moving that much. It's more your lower back, erector spinae. And similarly, squat is also not that great of a hamstring exercise. And a lot of people love to do squats for their leg workout, and that's it because they think it targets everything. And it does to an extent, but it's mainly a quad heavy exercise where you're just doing knee extension. It's not so much a hamstring one. So if you are doing squats primarily, make sure you do supplement with some kind of other hamstring exercise just so you get, or you don't get muscular imbalance. But most of you did say the correct one, which is glute hamstring raise. So leg curls aren't the best because you're only doing the flexion part of the knee, and all of the hamstrings do cross the knee, so they all are being activated for the leg curl, but you're only really doing one of the motions of the hamstrings. And if a muscle crosses the joint, it's better to work it out and do both exercises. And so glute hamstring raise does do the hip extension, but it also does the flexion as well, okay? And I just want to quickly mention, if you're only doing a hip extension exercise as your hamstrings, you're not even targeting that short head of the biceps at all. And so even though your legs might be really big, if you're not targeting that one head, you might also have muscular imbalance. So make sure that you're doing some sort of flexion exercise as well as an extension. But, okay, so just to quickly summarize, and then we'll get you out of here. So we talked about the bony landmarks. I probably mentioned them a gazillion times by now, so hopefully at least some of them stuck in your head. We talked about the glute muscles, a couple of adductors, the hamstring muscles, and then we talked a little bit about some clinical stuff. So I just want to say thanks a lot for listening to me ramble. I'd really appreciate any feedback if you wouldn't mind at some point filling that out. It takes as simple as 30 seconds. It really does help. But thanks a lot for your participation. And I will be posting my slides on OWL shortly. So if you want to look at those animations, feel free to check those out. Otherwise, enjoy the rest of your Thursday.